All right, so let's continue with parathyroid gland disorders and pituitary gland disorders. So let's look at calcium because we have to review the importance of calcium. Now we know calcium is important for bone strength. It's important for muscular contractions. It's important for clotting mechanisms. It's important for neurological impulses. Um, Calcium is extremely important. So keeping it within the blood in a certain tight, narrow range is extremely important. So the body gives us two glands to do that, the thyroid and the parathyroid. So right here in this picture, we can see the thyroid, which looks like the letter H, and then we can see the parathyroid, which is on the superior lobes and the inferior lobes of the thyroid, and they're called parathyroid. So let's say we have low blood calcium level. The low blood calcium level, it will stimulate the parathyroid gland to secrete parathyroid hormone. And parathyroid hormone's goal is to eventually take the low blood calcium and to increase it. Okay, so how is it going to do that? It's going to use three different methods. It's going to use the bones, the kidneys, and the GI tract. It's going to use the bones by increasing or stimulating the osteoclasts to release calcium from the bone, which increases the blood calcium level. It will tell the kidneys, hey, we don't want you releasing calcium in the nephron. We want you to retain that. So by retaining it and not peeing it out, that's another way of increasing blood calcium levels. And we're going to tell the GI tract to use vitamin D, calcitriol, or cholecalciferol to increase the absorption of calcium from the intestines, bring it into the blood vessels, which will increase the serum blood calcium level. When it increases the blood calcium level, there's a feedback loop, a negative feedback loop that goes to the parathyroid to inhibit the secretion of PTH. Okay? So hypoparathyroidism is when there's a congenital lack of the parathyroid glands. And that could happen from surgery or radiation to the throat region or an autoimmune disease. When there is hypocalcemia, decreased calcium in the blood, that can result in paresthesia. That can result in weak contraction of the heart, causing arrhythmias. That can result in increased excitability to nerves, which can result in spontaneous contraction of skeletal muscles, and you start to get these spasms or tetanus, which is cramping. There could be laryngospasm, fatigue, and headaches. So the opposite of that would be hyperparathyroidism. Now, that means that the parathyroid is working in overdrive, which will result in hypercalcium in the blood, hypercalcemia. And this could be a result of tumor, it could be secondary to kidney failure, or a paraneoplastic syndrome, some sort of tumor that's creating and promoting PTH production. So as a result of having too much calcium, you can have increased contractions of the heart, creating palpitations, chest pain, syncope, which could be fainting. If there is increased in calcium that's in the blood, well, that can result in osteoporosis because we don't want it in the blood, we want it in the bone. So that means you have bone pain, you have increased fractures, and if there's increased calcium in the blood, and you can form kidney stones as a result. There could be neurological issues, there could be fatigue, there could be confusion. So on the left, we have signs of hypocalcemia with hypoparathyroidism, and on the right, hypercalcemia. This is a typo. This should say hyperparathyroidism causes hypercalcemia, which results in fatigue, personality changes, decreased neural excitability. When you have hypocalcemia, it's increased neural excitability, tingling of the fingers. You'll have hyperactive reflexes with decreased calcium, hypocalcemia. There'll be muscle spasms, tetany, weak cardiac muscle contraction, arrhythmias, decreased blood pressure, hypotension. With hyper, you'll get decreased muscle tone. You'll get forced cardiac contraction, arrhythmias, bradycardia, hypertension. With the kidneys, polyuria, thirst, kidney stones, renal calculi. There'll be constipation, nausea, decreased peristaltic contractions, and you'll get osteoporosis, which will result in bone fractures of the weight-bearing bones. So the treatment of the parathyroid disorder really depends on the cause. So the underlying disorder has to be treated. If it's hypoparathyroidism, then calcium and vitamin D would be very beneficial. And if it's hyperparathyroidism, then they'll typically remove the parathyroid glands, okay, without affecting the thyroid gland. Adenocarcinomas are the most common cause of pituitary tumors, and this is when there is a mass that starts to increase around the pituitary, and that could put pressure on the skull, which can result in headache, seizure, drowsiness, and can create visual effects, visual deficits. When you look at the pituitary gland sits right next to the optic chiasm, where both optic nerves crisscross, where that sella turcica is. So if the pituitary gland enlarges and puts pressure on the optic nerves, there'll be visual deficits. The effect on the hormone secretion depends on the cells and the location. Is it affecting the anterior pituitary? Is it affecting the posterior pituitary? And it can cause either an excess or decreased release of hormone. So you have to know the location and the hormones affected, and is it too much or too little. So you have to review both anterior lobe and posterior lobe. When you look at the anterior lobe, that's involved with releasing adrenocorticotropic hormone. Now, the only way that whether the anterior pituitary or posterior pituitary can release their hormones is by it receiving a chemical message from what's above it, which is the hypothalamus. Okay, so the hypothalamus sends a signal to the anterior lobe to release adrenocorticotropic hormone. It goes to the adrenal gland, and it goes to the cortex because it's adrenocorticotropic hormone. It goes to the cortex. The medulla is stimulated by the hypothalamus directly. Okay, the adrenal medulla pushes out norepinephrine and epinephrine. The adrenal cortex pushes out cortisol, cortisone, corticosterone, aldosterone. Then you have thyroid stimulating hormone that stimulates the thyroid to push out T4. And then T4 gets converted to T3 at the level of the liver. We said it's selenium dependent. You also need fat in your diet because the receptors on the thyroid is fat. So TSH needs to hit the receptor on the thyroid to push out T4, and that's fat soluble. So having good healthy liver and gallbladder is important to break down the fats to put it on the receptor site here. Growth hormone, prolactin releasing hormone, follicular stimulating hormone affects both gonads, male and female. Luteinizing hormone affects both male and female. Melanocyte stimulating hormone, the melanocyte. Oxytocin affects both male and female. And then ADH, antidiuretic hormone, the kidneys. So the anterior pituitary deals with a lot of hormones. The posterior, the neurohypophysis, not too much, just ADH and oxytocin. So again, take some time to just review, right? This was done in A&P, review the main hormones, and then know what their principal actions are. Because when there are hormones that affect these organs, you can almost predict what the deficit will be. So for example, if we look at growth hormone, well, if there's too much or too little, well, if there's too little, it's going to be decrease in height. If there's too much, increase in growth. So dwarfism is a deficit in growth hormone production and the release, whereas giantism and acromegalia or acromegaly is an excessive amount. It just depends on whether it's in children or adults. So giantism is excessive growth hormone prior to puberty and the closure of the growth plates, which is in the epiphysis, when you're a child, after the growth plates have closed and there's increased growth hormone secretion, there's going to be this acromegaly, where they have this kind of like caveman Neanderthalish type of look. So here is giantism, and here is dwarfism. Here is giantism. This is something different. This is called acromegalia. This happens when you're an adult. Okay? Just look at the thickened brow, right? It has this look at the protruding jaw. This is acromegalia. This is acromegalia. Large, thick hands, large brow, large nose, large features. Here's one. This is a famous one for acromegaly. Here's the young girl when she's 9. Then she's 16. At this point, probably her growth plates have closed, and now at age 33, look at the change in the facial features, and look at the change in the brow, look at the change in the forehead, look at the hands, look at the jaw, right? This is a anterior pituitary lesion where her body keeps pushing out growth hormone. Now, when there's a pituitary issue of the posterior pituitary, remember diabetes insipidus, this is a deficit of antidiuretic hormone. This originates in the posterior pituitary or the neurohypophysis, and this can result from head injury or also surgery. There's the nephrogenic form, which means the kidneys are not responding to the antidiuretic hormone. And when there's no antidiuretic, then what happens to the urination? Polyuria, with large volumes of diluted urine, and then you become very thirsty. So there's polyuria and polydipsia, polyuria and polydipsia. Then there's another ADH disorder called inappropriate ADH syndrome. This is when there's the excessive amount of antidiuretic. So now you're not urinating a lot. There's the fluid retention. When you hold on, when there's fluid retention, you're not going to the bathroom as much. So this may be temporary. It could be triggered by stress, maybe secreted by an ectopic source, such as a tumor. So this is the clinical manifestation, is fluid retention. When you're holding on to fluid, you're in a state of hyponatremia, which means there's less sodium in tissues and in the blood because it's pulled into there's less sodium that's available to use because you have hyponatremia. When you hold on to fluid, the minerals like sodium follow the fluid. The treatment is a diuretic, okay? And then when you treat with diuretics, then what happens? Now, if you're losing the water from the diuretic, then you're going to lose sodium in the blood, and now you become hyponatremia. Now there's decreased sodium in the blood, and it has more negative side effects. So what would be the result? Sodium supplements, increased salt in the diet, or salt pills. Okay, we'll pause here, and then we'll continue on with thyroid gland disorders and adrenal gland disorders.